So just look at this image in which we can see the major components of hemostasis. It starts with a vascular injury that leads to vasoconstriction. Then the collagen leads to platelet activation, which then their von Willebrand factor and fibrinogen comes, and they start making a platelet plug. Simultaneously, because of the tissue factor, the coagulation cascade is activated also. So it is a kind of a both-way traffic. Like platelet activation leads to coagulation cascade activation, and coagulation cascade also leads to the platelet activation. So when the platelet activation happens with the help of von Willebrand factor and fibrinogen, there is a formation of platelet plug, and this is called primary hemostasis. Hemostasis is a body's physiological condition in which the body wants to seal the repair. So this primary hemostasis is the temporary seal, and then it goes to the coagulation pathway where there is formation of thrombin. Thrombin comes into action, which leads the fibrinogen to degrade into fibrin, and finally a blood clot is formed, which is because of secondary hemostasis. And till the time the primary repair is done, after that the body tries to fibrinolyze it and the clot degradation. So this is what the hemostasis is all about. But during the primary platelet adhesion, the platelet remains very unactivated, but after its activation, there is rolling of the rolling happens of the platelet over the injured endothelium. Then there is adhesion of the platelet. Granules are released, granules in the form of ADPs and all the receptors and the small particles that comes, and which leads to the formation of platelet aggregate. There are lots of receptors which are engaged in it, GP2B3A and von Willebrand factor, which helps in more and more involvement of this receptors. Then if we look at this diagram, in which we can see this is something a normal part where this the collagen is intact, then smooth muscle, tissue factor, and endothelium. But as soon as the primary hemostasis has to happen because of some injury, the platelet has lots of receptors coming over it, in which there is the more and more platelets comes in, and they kept on binding with the help of von Willebrand factor and fibrinogen. The primary motive is just to making a platelet aggregation and a clot so that it can repair the injury. And then the secondary hemostasis that comes with the help of coagulation cascade in the form of extrinsic pathway and intrinsic pathway. Intrinsic pathway, extrinsic starts with the factor 7A, which becomes activated because of tissue factors. And in case of intrinsic pathway, it is the pre-kallikrein kininogen which comes, which activate the factors 12 into 12A, 11 to 11A, and so on. There are lots of autocatalytic the coagulation factors like 5, 8, and 10. As soon as factor 10 is activated, it activates 5A and prothrombin converted to thrombin, then finally fibrin to fibrinogen to fibrin, and finally fibrin with the help of other coagulation factors. So the point factor 10A comes into action, it becomes extrinsic and intrinsic to a final pathway which is common to both of them. Then the body's other mechanism comes into act, that is thrombin and antithrombin 3, which comes and tissue plasminogen activator. They try to just degrade this product that has been formed here. This is what I had discussed here, like intrinsic pathway and extrinsic pathway. Start from tissue factor, factor 3, factor 7. If there is any deficiency, we all know it. Factor 11 is hemophilia C, factor 8 hemophilia E. And if there is quantitative defect or the qualitative defect, then it is von Willebrand factor disease 2. And hemophilia B is factor 9 deficiency. So this is the pathway, and we all see here that the most common chelating agent or the cation that acts here is the calcium. Now, to summarize it, there are 6 phases of blood clotting. It starts with the vascular phase where there is vasoconstriction. platelet phase, platelet aggregation, then coagulation phase, thrombin formation phase, clot formation and stabilization, and finally the dissolution of clot when the repair has been totally done. Why we are talking so much about the platelet? Because the platelet function is important, because if there is hypertension, there is membrane setting, blood flow, anosynthesis, and cytokine production. This all can lead to hypertension and can lead to acceleration of the hypertension and atherosclerosis. In COVID-19, we had seen that it was a hypercoagulable state, which was also affecting platelet. In cancer biology, tumor metastasis, tumor growth, vascular integrity, angiogenesis. So this platelet, whatever situation happen, be it inflammation, atherosclerosis, any kind of oxidative stress or immunity, there we see that the platelet is one of the important blood cells that gets activated. And because of this, the hemostasis and thrombosis in the body gets altered, and we have to take care of it. As I was discussing it, platelet activation because of some microbes, because of inflammation, clot formation, diabetes, angiogenesis, or whatever, lots of changes happens in the body, and platelet is one of the most favorite culprit that play the role in doing so. Common causes of some acquired thrombocytopenia. In what cases the platelet becomes means non-functional, be it qualitative or quantitative? There can be, we are just going to understand it in a three important headings. First is there is impaired production. Everything is fine, but production is hampered. It happens because of some nutritional deficiency, myelocytic anemia, hemophagocytosis, ITP, cytotoxic drugs, increased destruction. There is no issue with the platelet formation, but it is being destroyed more. It happens in case of mostly autoimmune diseases or some hemophagocytosis. We all know arbovirus, dengue, chikungunya, and in these diseases, it can happen because of dilutional issue like hypersplenism, or if we are transfusing patient with more of the blood. So what happened? There is a ruptured plaque. Suppose there is platelet aggregation and it makes a plaque somewhere. So if the plaque is ruptured, then there is collagen or thrombin is released. This happens when there is atherosclerosis or any kind of endothelial damage that has happened. Initially, a thrombus is formed there, which turns into plaque because of the covering of the endothelium or the other tunica layers, and it makes a plaque. And plaque has the tendency to get ruptured in case of any kind of an insult. So when the plaque is ruptured, then collagen and thrombin comes out. And from this collagen, because of the phospholipids presents, if the with the help of COX, there is a release of thromboxane A2, which is a potent platelet aggregator. Then ADP, which also causes conformational change in GP2B3A, and platelet coagulant activity thrombin. All of this leads to platelet aggregation. I have shown here the drugs which comes into action preventing this, like COX inhibitor, then ticlopidine and GP2B3 antagonist. I am going to discuss this in upcoming slides. This is again what I was telling, like thromboxane A2 or PGI2, this is being released from the arachidonic acid present in the phospholipid on which cyclooxygenase act. And this is a potent thromboxane A2, it is a potent platelet aggregator. PGI2, that is prostaglandin I, is a potent vasodilator. But all of this action happens with the help of cyclooxygenase 1. And then ADP, I am skipping this slide as I am going to discuss it in further slides too. So let's start with the proper pharmacotherapy or the pharmacology of anticoagulants and antiplatelet drugs. So just we are going to keep it very simple, how to classify antiplatelet drugs. There are two domains: anticoagulant, which acts on the coagulation cascade, and antiplatelets, which acts on mainly on the platelet or the platelet mechanism by it makes the clot. So the first group is cyclooxygenase inhibitor, and the most famous drug with that we all use left and right is aspirin. Second is phosphodiesterase inhibitor, the two drug that is dipyridamole and cilostazol. Pyridamole is a phosphodiesterase 3 and phosphodiesterase 5 inhibitor both, but cilostazol is mainly for the phosphodiesterase 3. So how does it act? Phosphodiesterase inhibitor does not let the metabolism of cyclic AMP to happen, which helps in the dilation of the vessel. So if any way we are going to inhibit it, then these are being used. Cilostazol is a common drug used in peripheral vascular disease. Pyridamole, dipyridamole is used in some kind of cardiac diseases. Then coming to ADP P2Y2 receptor blockers, we are going to divide it into two parts, reversible and irreversible. Irreversible action is ticlopidine, clopidogrel, and prasugrel. All of these drugs can be given orally. Reversible, cangrelor, which is given IV, and ticagrelor, which is given oral. Then GP2B and 3 antagonist is epciximab and iftifibatide, tirofiban. Epciximab, the name implies it is a monoclonal antibody, MAB. And then the last, the new category of drug that has come is protease activating receptor 1 antagonist. This is vorapaxar and etopapaxar. Now coming to the anticoagulants, we are going to classify into two parts, the drug that can be given orally and the drug that can be given parenteral. Oral groups is vitamin K inhibitors, most commonly is warfarin, dicumarol, acinocumarine, phenindione. And oral that acts on factor 10A inhibitor are rivaroxaban and apixaban. We can see in the name X and A, it acts on the 10A factor, that is factor 10A factors. So this is factor 10A inhibitor. Direct thrombin inhibitors, the common name that we use is DOAC. Direct oral thrombin inhibitors are zimelangatran and dabigatran. And amongst the parenteral, it is indirect or direct. Indirect is unfractionated heparin. Low molecular weight heparin is heparin. Heparin is enoxaparin, dalteparin, and tinjaparin, and fondaparinox and idraparinox. Then direct thrombin inhibitors are hirudin, lepirudin, bivalirudin, ergotropen, and melagatran. To note here is that these all are parenteral, and this is the left-hand side one is the oral one. So how does it act? Vitamin K helps in the activation of 4 factors. The factors are 9, 7, 10, and 2. So if we are anyway affecting the metabolism vitamin K, that is vitamin K quinone, it gets reduced while doing the carboxylation of the these 2, 7, 9, and 10 factor along with protein C and S, and it has to come back to its normal form to react on the other factors. So the warfarin or the warfarin congeners, what they do, they inhibit this enzyme which is called vitamin K reductase. So warfarin or the dicumarone derivative are vitamin K reductase inhibitor. They inhibit this enzyme and does not let this vitamin K to be free to carboxylate the glutamyl residue of the factor 2, 7, 9, and 10, and a few anticoagulant factors like protein C, protein S. It is important to note the half-lives of vitamin K dependent clotting factors. The clotting factors are factor 7, 6 to 8 hours, factor 9, 24 hours, factor 10, 25 to 60 hours, and factor 2, 50 to 80 hours. Why this is important, I am going to tell you in the next slides. So this is one of the important diagram where we are going to see which all part the drugs acts. We can see in the extrinsic part, which starts from the activated platelet and this. So these are factor 7, then common pathway, fibrinogen. If we are going to inhibit this factor 7 with the help of warfarin or heparin, because warfarin inhibit vitamin K. Vitamin K does not help in the activation of factor 7. Then if you look at thrombin acts on the factor 5, does not lead to autocatalyze it. Then DOAC, which acts on the direct thrombin inhibitor. So in this way, these are the drugs which acts on different parts. I told you that there are directly 10 inhibitor like rivaroxaban or apixaban, which inhibits then factor 10A and hence inhibit the common pathway onwards. Now, after that, knowing antiplatelet and anticoagulant, we'll come to know about fibrinolytics and thrombolytics, which after formation of the clot, lyse it. So this is streptokinase and urokinase. Then coming to recombinant tissue plasminogen activator, LT-place, RT-place, and tenecteplase. Tenecteplase has a longer half-life. And antifibrinolytics, which exactly acts opposite to fibrinolytics drugs. It helps in formation of clots like epsilon aminocaproic acid and tranexamic acid. Famous name is Tranexa, with which we use it. And others plasma expander, which helps in sometimes in expanding the plasma. Albumin, which is one of our plasma proteins of the body, dextran 40, dextran 70, polygellin and hetastarch. Albumin and polygellin does not interfere with blood grouping and cross-matching. So this is how the plasminogen comes when there is a clot formation. Plasminogen activates plasmin, and ultimately this fibrinogen gets degraded into fibrin degradation product. Here comes two drugs which promote it, is fibrinolytics, that is LT-place or streptokinase or these drugs. And if we have to promote the clot formation, then it is inhibited by aminocaproic acid and tranexamic acid. After knowing this, let's know something about the pharmacokinetic and pharmacodynamics of these oral anticoagulants. Oral anticoagulants, warfarin, mechanism I've told how it acts. It is a vitamin K epoxide reductase inhibitor. It is not a prodrug, extensively metabolized by CYP2C9. It is important to note that warfarin does not require any renal dose adjustment. Can be safely given in renal failure. Dialyzable, answer is no. Pharmacodynamics binding to effector, it is irreversible. Dabigatran. Dabigatran is a direct thrombin inhibitor. It is a prodrug, yes, metabolized by kidney. So it has to drug modification, or if the patient has advanced kidney disease, then we can't give it. And the effect is reversible. Then apixaban, the name implies XA, means it acts on the XA inhibitor, metabolized by liver. Renal dose adjustment need not to be done. Apixaban, it is one of the most commonly used this XA inhibitor, which is given when the patient is having non-valvular atrial fibrillation, and the effect is again reversible. Rivaroxaban, it is metabolized by kidney, so you have to be cautious when you're dealing with patient having kidney issue. Edoxaban, again, it comes out of the kidney. Additional pharmacokinetic properties in normal kidney function, I've told what is the Cmax, 2 to 6 hours, 1 to 2 hours, and T half is 42 hours, 12 to 14 hours, 12 hours, 6 to 13 hours, and this. Why it is important? It is just a table. The answer is this: no. It's not just a table. It is a many more things that we can come out of it. First thing is just look at warfarin. Warfarin's protein binding is 97 to 99%. So the drug that comes into action is 1 to 2% only. Supposedly, any drugs comes which led the warfarins to less bind with the protein. So suppose initially it was binding to the protein with 99%, and suddenly a drug comes which is making its binding to the protein with 98%. So initially the available drug was 1%, but now it is 2%, exactly double. So whenever you are using warfarin, you have to make sure that the drug interaction has to be minimal. And the volume of distribution is 10 liters. Bioavailability is very high, 99%. So it is very good if you give oral warfarin. Dabigatran, protein binding is 38%. Bioavailability is not very good. So we try to check In the bioavailability, depending on the patient's condition, Apixaban very well orally tolerated. We gave it. Protein binding is 87%. Rivaroxaban, because of its longer half-life, we can see it here. It is being used more popularly. So this is what this oral anticoagulant is. This I have told a few more table that is taken from the American Heart Association. Absorption with food. Most of them has no effect on the food. The absorption with any PPI or that thing that has to be taken care, but not necessarily if the patient is taking any DOAC. Elimination half-life is important. It decides how frequently we can use this drug, because if the half-life is 12 hours, the drug has to be given twice daily. If it is more than 24 hours, then the drug can be given once a day. And dialysability, it helps when the patient is having kidney disease. So where to use these drugs? These drugs is most popularly used in anticoagulant is used when the patient is having venous thromboembolism. This is a table taken from the American Heart Association, and as per the ACC guidelines, they have given two scores, that is PADUA score and improved scores. The risk factors that has to be noted is active cancer, prior history of venous thromboembolism, reduced mobility, thrombophilia, recent trauma or surgery, age more than 70 years, heart or respiratory failure, acute MI, recent infection, obesity, hormone therapy. If it becomes high thrombosis risk, if the score is more or equal to 4, and if it is less than 4, then you can wait. So if the patient is having more improved or more PADUA score, you have to start patients giving anticoagulant therapy. So anticoagulant therapy can be of two. Either it can be prophylactic, where you are preventing the patient to land up into any kind of a catastrophe, or it can be therapeutic. So we have to understand, if this risk factor are there, and risk factor is more than 4 point wise, then you have to start it, but that has to be in the prophylactic dose. And if the patient has any kind of a embolism or any kind of a thrombosis in the body, then you have to start in the therapeutic dose. Risk stratification and patient-specific peri-procedural thromboembolism. If the patient has undergoing any kind of a procedure, what is the risk? The risk is high, more than 10%, if the patient is having any mechanical heart valve, if the patient is having already atrial fibrillation or any venous thromboembolism in last 3 months. So atrial fibrillation, we are going to check with the CHAD S2 and VS score, which includes congestive heart failure, hypertension, age, diabetes, prior stroke, prior venous thromboembolism history. Considering this, we are going to decide the patient whether which they'll end up into high category, which is more than 10%, moderate 4 to 10%, or low less than 4%. And depending on that, we are going to start the thromboembolism prophylaxis or the therapy to the patient. This is as per the ACC and AHA guidelines. This is latest 2025 guidelines about the use of antiplatelet drugs. Suppose a patient presents with acute coronary syndrome to you. So you have two options. Either you can give anticoagulation or antiplatelet. The answer is no, you have to give both, because these both have two different mechanisms, and depending on the patient's condition, you have to start it. So a patient has acute coronary syndrome, you have to load the patient with aspirin, 75 milligrams tablet, 4 tablet, and you have to give some P2Y2 inhibitors. That is, we commonly give some kind of a clopidogrel or some other drug. So clopidogrel that you have to give. The green one is the strong recommendation. The red one is the grade 2B, and the yellow one is grade 2A. So whatever being seeing here, green is strong recommendation that you have to give. The anticoagulation of choice will be unfractionated heparin. The two reasons. First thing is it is a faster acting one. Second is we have got antidote available, protamine sulfate. In case of very severe bleeding on any kind of a thing, we are going to reverse its effect. During coronary revascularization, aspirin and P2Y2 inhibitor has to be continued. Ticagrelor or prasugrelor instead of clopidogrel are the strong recommendation because of more reliable antiplatelet action on it. Cangrelor, they are avoiding not to be used because of it causes severe neutropenia. Then GP2B3B inhibitor, not a good recommendation. And routine use of GP2B3 inhibitor is not recommended at all. And amongst the anticoagulation, unfractionated heparin, you can use bivalirudin instead of unfractionated heparin when there is STEMI, and bivalirudin instead of unfractionated heparin when there is NSTEMI is not a good recommendation. Post-catheterization, when the patient has undergone coronary revascularization, during the discharge process, you have to give aspirin and P2Y2 Y12 inhibitor at least for 1 year. Low bleeding risk. Again, this is a very long discussion, like whom to consider, how long, what kind of stent the patient has got, what kind of procedure patient underwent. But in basic, it has to be given for 1 year. Ticagrelor monotherapy after 1 month of post-PCI to reduce bleeding events. Instead of giving dual antiplatelet drugs, we can take the patient on ticagrelor. This is one of the latest recommendation, but after 1 month. And giving P2Y2 inhibitor de-escalation after clopidogrel, these are all the not a good recommendation. High dose bivalirudin 2 to 4 hours post PCI in STEMI. This has to be continued when patient is in the hospital. Again, coming to before PCI, we are comparing the guidelines like American Heart Association 2025 with the 13 and 14 and European Society of Cardiology. Pre-treatment with P2I2 inhibitor in patient with ACS planned for any invasive strategy for more than 24 hours. The ACC is telling as a grade 2B recommendation to be given. Initially, it was questionable. And I am just going to tell the strong recommendation. During the PCI, parenteral anticoagulation using heparin, during primary PCI and STEMI and other patient with ACS at the time of diagnosis. All the 3 guidelines are strongly recommending it. Now, ACC AHA guidelines is asking to use bivalirudin with high dose post PCI infusion as an alternative to unfractionated heparin in patients with STEMI undergoing PCI. Previously, it was questionable, but now they are putting more emphasis on it. Bivalirudin as an alternative to unfractionated heparin in patient with non-STEMI ACS undergoing PRASV, it is still not very good recommendation. Initially, it was questionable. Fondaparinux or enoxaparin to be used in early invasive angiography is not anticipated if it is less than 24 hours. It is strong recommendation. You are not supposed to use it. Use of dual antiplatelet drugs is again has to be used with aspirin and one of the P2Y12 inhibitors, minimum to be given for 12 months. It is as per both the AHA and European Society guidelines. And preference of drugs will be ticagrelor or prasugrelor over clopidogrel because of more reliable effect when patient is come out of the PCI and sent back to home. Preference of prasugrel over ticagrelor in patient who proceed to PCI, going for that is again still questionable. And clopidogrel, when prasugrel and ticagrelor are unavailable, cannot be tolerated, are contraindicated, should not be given. De-escalation from DAPT, dual antiplatelet drug, to single antiplatelet drug with ticagrelor and after 1 month is strong recommendation, already being discussed. We all see that a few of the Ayurvedic medication, lots of patients present, they used to take garlic or ginkgo or ginseng. These all have some kind of antiplatelet or anticoagulant effect in the body. And how long it takes, this is one of the important MCQ. Sometimes it comes. Garlic takes 7 days, ginkgo takes 36 hours, and ginseng 24 hours. For the normal homeostasis after their discontinuation. Sorry. Categorization of the DOAC doses depending on the different condition. Rivaroxaban, apixaban, edoxaban, and dabigatran. If you are using it for the venous thromboembolism, then the dose is 10 milligram daily. Apixaban 2.5, Indoxaban, it is not given orally, usually not recommended. Dabigatran 220 milligram for 1 day, then you have to change it depending on the creatinine clearance. Stroke prevention, rivaroxaban 20, 5 milligrams, 60. This is as per the American Heart Association guidelines. Again, and the dose become more and the frequency become more, as we can see it here. Venous thromboembolism prophylaxis. Rivaroxaban is 10 milligram daily, but if we are treating it, then it is 15 milligram twice daily for 21 days, then it has to be continued. Extended prevention of recurrent TVT or P, then the dose is same, but it has to be continued regular. And apixaban does not require any kind of a dose modification if the patient is having any renal disorder, but the others require dose modification. Acute coronary syndrome, so starts with low doses. Only rivaroxaban is approved by FDA for use in acute coronary syndrome. Rest all are not. Prevention of atherosclerotic event, only rivaroxaban. This is how when the body's mechanism is jeopardized, then we know that what's triad is blood flow, blood viscosity, and vessel wall. If there is any issue with this, like blood flow, when there is any kind of a stasis, blood viscosity, when it becomes hypercoagulability, and when there is endothelial injury, these all are the factor which leads to the formation of thrombosis in the body. So what happens? Hypercoagulability, thrombin, antithrombin complex, the number increases, fibrinogen increase, D-dimer increase, and so on. Endothelial microparticles like soluble tissue factor release, surface tissue factor release, this happens, and platelet dysfunction happens. All of this leads to the RAS activation in the body, and this RAS activation causes endothelial dysfunction and vascular remodeling. So that is why whenever there is any kind of a stasis or any kind of endothelial damage or any risk factor which can lead to this, we need to address all of this factor together. Otherwise, it is going to affect our vital organ of the body, be it heart, be it blood vessel, be it lungs or kidney. This is again European Society of Nephrology has given some kind of use of this DOAC and anticoagulation drugs. This is not very important. This is for day-to-day practice. I told, if the patient is having low clearance below 60, then the drug require monitoring and their dose has to be adjusted. But if it goes below 15, then only drug which does not come out of the kidney has to be used. Otherwise, with the drug modification up to 30 ml per minute, we can use these drugs. So we can see it here, warfarin with the INR of 2 to 3 can be used if the patient is having clearance of 30 to 59. And in all the cases, only it needs a bit of titration. Only it needs a bit of titration. Otherwise, warfarin is a safer alternative if the patient is having any kind of a kidney disease. Apixaban with the dose modification can be used safely in case of a kidney disorder, even if the creatinine is less than 15. Rivaroxaban is not recommended if the creatinine clearance goes below 15. Edoxaban is also not recommended. To note from this, renal disorder, two anticoagulant can be used, warfarin and apixaban. Other drugs can be used, but provided the creatinine clearance is up to 30 and those drugs needs drug modification. This is again as per the European Medicine Agency. They two societies, European Medicine Agency and European Guidelines for the Nephrology. They have given their difference dosing, the dosing rates. Creatinine clearance of 15 to 30 as per FDA. They are telling 75 milligram BIT to be used, and the EMA is strictly contraindicating. Dialyzing patient, they are contraindicating it. Apixaban, the two society, they want dose modification. If creatinine clearance is 15, the European Medicine Agency is much more strict on the renal clearance. They have even stopped apixaban, and rivaroxaban, limited data. Indoxaban is not being used. if any kind of anticoagulation therapy leads to toxicity, how to reverse it? Warfarin, is it reversed by antidotes? Prothrombin complex concentrate, if you are using, yes. Recombinant 7A, yes. Fresh frozen plasma, yes. Specific antidote is available. We can give vitamin K, but it takes some time. So we can use prothrombin complex concentrate, recombinant factor 7 or FFP if there is warfarin toxicity. If there is dabigatran toxicity, it can be reversed by idarucizumab, which is a specific antidote. Rest any of the factor, if we are using, it is not going to work on it. Rivaroxaban, it is a factor 10A inhibitor. So prothrombin complex concentrate or factor 7A or FFP, which is going to let the body make more 10A factor, it is beneficial. Apixaban, Adinexanet alpha, it is under investigation, not being out in the market, not being approved. So these all factors can help with apixaban and edoxaban. Again, these all factors can use. Hemodialysis can only help with the patient is having dabigatran as a treatment modality in its toxicity. Now, after knowing this, that is something more important. Most of our juniors or our students, they keeps on asking us like when of these drugs to be used if the patient was taking prior to surgery or any procedure. The last recommendation that came in 2020 by American Society of Regional Anesthesia, I am sharing today most updated guidelines by the Stanford Healthcare, Stanford Medicine. To note it here, if the patient is having any kind of a neuraxial involvement procedure. Why all the guidelines based on neuraxial? Because if any procedure can be done near spinal cord, that procedure is going to be very safe. Because if in the spinal cavity, if in the subarachnoid space or anywhere, any thrombus is formed, that is going to leading to the compression of the spinal cord and patient leads into paralysis. So if we are so much confident that it is not going to produce any spinal hematoma, then it is safe that during the surgery in other places bleeding can be controlled. So if neuraxial block can be given in a patient, then obvious other surgery can be performed too. So if we are using the prophylactic doses of heparin, that has to be stopped 4 to 6 hours prior to any neuraxial block, be in the form of spinal, epidural, or we are doing any kind of a lumbar puncture. If there is very emergency, you please verify with the APTT, which is one of the intrinsic pathway factor. Heparin is being monitored by APTT only. During if the catheter is in situ, you can use heparin, but prefer to use some alternative. After removal of the catheter or after doing the blockage, after 1 hour, you can give heparin. If you are using heparin infusion, you have to be much more cautious, but you have to follow the same thing. So heparin prophylactic dose, 4 to 6 hours. Heparin therapeutic dose, wait for 12 hours before you start any surgery or any neuraxial blockade. And it is 1 hour if you are taking the neuraxial blockade or the catheter out of it to reuse it. Deltaparin, if patient is on it, if it is contraindicated, do not do it because you have to wait for longer. If you are using any enoxaparin, low molecular weight heparin, it is exactly double of the heparin. 12 hours. If it is prophylactic, it becomes 24 hours or more than it if you are using it for therapeutic purpose. And 4 hours you have to wait after removing the catheter out of it to reuse it. And when the catheter is in situ, please do not use enoxaparin or any of the enoxaparin, even if in lower dose or higher dose. Fondaparinux, you have to wait for 36 to 48 hours and post removal of the catheter for 6 hours. Apixaban, common brand is Eliquis. 3 days you have to wait for any kind of a surgery or any blockade. During when the catheter is in situ, don't give any apixaban. And after removal of the catheter, you can reuse it after 6 hours. Rivaroxaban, 3 days. Betrixaban, 3 days. Indoxaban, 3 days. So apixaban, any 10A inhibitor, 10A takes 60 to 72 hours to reformed in the body. So after 3 days, you can get surgery done or any of the procedure done. And after on an average, after 6 hours, you can reuse it after removal of the catheter. Dabigatran, based on the creatinine clearance. If the kidney function is very fine, then you can use it after 5 days. To just keep it in mind, it is 5 days on an average. Warfarin 4 to 5 days. Verify with the normal INR whether it has come below 1.5 or not. If it is 1.5, you can remove the catheter and reuse it. Then direct thrombin inhibitors. Hello?
Yes, sir.
Direct thrombin inhibitors. LT-Plays. LT-Plays, then it is contraindicated if the patient has received any kind of a LT-Plays or a TPA to use any surgery or putting any epidural catheter, because this can lead to the higher chance of bleeding.